Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Schaza Rana. Dr. Rana is a third-year internal medicine resident with a strong passion for medicine, particularly in the fields of pulmonology and critical care. Join me in welcoming Dr. Rana.
Good afternoon, everyone. Thank you for being here for my presentation. I'm Dr. Rana. I'm one of the third-year internal medicine residents, and the topic to my presentation for the Grand Rounds is More Power to the Lung, Managing Pulmonary Embolism. Why did I choose this topic? Pulmonary embolism is the third most common cause of hospitalization and of course adds to the hospital burden in the US. There are new advancements in the guidelines that are focused on risk stratification, which drives the management. So this is what my Grand Round presentation would be. I do not have any financial disclosures. All right, so just objectives to my presentation. I will be starting with the scope of the problem. We'll be talking about the pathophysiology and the clinical presentation. What guidelines do we follow? What are the new ways of robust risk stratification? Right ventricular failure, and we learned the importance of that in pulmonary embolism, is an important component, and we'll be talking separately about that. We would talk about some individual management based on case presentations, and then we'd be talking about the treatment options, anticoagulation, thrombolytics, catheter-directed devices, and complications. We would be touching base on the PERT team, and then also some role of artificial intelligence in pulmonary embolism. So starting from the scope of the problem, as I mentioned, pulmonary embolism is the third leading cause of hospitalization in the US, and that is after the cardiovascular and the stroke. Of course, it is categorized into different risk stratification categories, and based on that, it does add to the mortality. So if you see here, approximately 350,000 to 600,000 cases of venous thromboembolic diseases are in the US annually, out of which 100,000 to 200,000 deaths are related to it. If someone is in the hospital, almost greater than 50% of the hospitalized patients are at a risk of venous thromboembolic disease. It is to note that the incidence of PE is rising, but the mortality is decreasing, and that is because of the new treatment options that are available. So, touching base on the pathophysiology, we all know the watch-out triad, which is a link between hypercoagulability, endothelial damage, and hemodynamic complications. Once that starts to happen in the body, the healthy endothelium on the left, which shows a laminar blood flow, that converts to the one on the right, which is dysfunctional endothelium, leading to a cascade of reactions. So initial insult to the endothelium can cause the release of von Willebrand factor, can cause the release of ATP, thromboxane, calcium, resulting in clot formation, and then it goes into the coagulation cascade. Ultimately, we do have a thrombus formation, and then a part of the thrombus would break down and can travel as an emboli, in this case to the lung. Very simple slide describing different pathophysiology involved in pulmonary embolism. So at baseline on the top, we have the baseline lung, but with pulmonary embolism, we have increased vascular resistance. Also, there is normal gas exchange in the lungs, but because of some irritant receptors in the lung, there is impairment of gas exchange. There is bronchoconstriction, and also there is lung edema and hemorrhage. So how do patients present? When we have a patient presenting with pulmonary embolism, there could be a variety of symptoms, but the most common would be difficulty breathing, coughing up blood, faster than normal or irregular heartbeat, and chest pain that worsens with deep breathing or coughing. Vital signs, patients can present with tachycardia, hypoxia, shock index, which is systolic blood pressure upon heart rate, If that's above 0.89, that's indicative of poor outcome in right ventricular dysfunction, which is an important component of pulmonary embolism. Labs, we can have, we'll have a variety of labs sent in the ED, but the specifics for us would be NT-proBNP, troponin, and BMP. In BMP, we are more focused on the creatinine. Also, lactic acid is an important lab because lactate and creatinine are associated with mortality outcome. If you do an echo on the patients in pulmonary embolism, we'll have the RV to LV ratio. If that's greater than 0.9, typically it should be less than 0.9. Greater than 0.9 and per European Society of Cardiology guidelines, greater than 1, then that's considered abnormal. Also TAPSE, which is the tricuspid annular plane systolic excursion, literally, which means the anterior movement of the tricuspid valve. If that's less than 20 millimeter, that's specific for pulmonary embolism and all-cause mortality. We also have something called the McConnell sign, where if you see in the picture, the apex of the right ventricle is contracting, but there's akinesia of the right ventricle free wall. So it gives that appearance, and it's called the McConnell sign. That's also specific for pulmonary embolism. And then if we do a CT imaging, we'll again have the RV to LV ratio, and then we can also have hepatic reflux, and we can have clot in transit. In special population, example, pregnant patients, we may put them under VQ scan, which would help us diagnose the condition. And this is a CT of the CTA. It just shows the RV to LV ratio. That's approximately 1. So following the script, what guidelines are we following? We have multiple guidelines in pulmonary embolism. We have the European Society of Cardiology and Respiratory Society. These guidelines were updated in 2024. We also have the CHEST guidelines updated in 2021, the ASH updated in 2020. We also have the AHA guideline, PERT consortium, which is an important part of pulmonary embolism, discovered almost a decade ago. Those guidelines, that's an annual conference that happens in the fall. They update the guidelines, and then we have the NICE guidelines. So based on the most recent guidelines that we have, let's focus on the things that actually differed. So there has been a shift of the usual pulmonary embolism that we know. We all are aware of the massive, submassive, and the non-massive pulmonary embolism. There has been a shift to risk stratification. This was first presented by the European Society of Cardiology in 2019 and has now been reinforced in their guidelines in 2024. We have a 4-tier approach. Basically, high-risk patients, intermediate have 2 types of risks, so intermediate high and intermediate low risk, and then we have the low risk people. CHEST does not follow any of the tier systems, but they do focus on PESI and SPESI scoring system. Same goes for ASH. Now, why is this tier system important? Because of this recent trend, all the management's recent research is all directed based on the high, intermediate, low, and low risk stratification. For ESC in 2024, they still stick with the scores, and we will be discussing the scores shortly. Biomarkers, which would be specifically troponin and proBNP, including D-dimer, and then imaging. There has been a concept of age-adjusted D-dimer, and that comes from the CHEST 2021. In terms of outpatient treatment, we have the European Society recommending the SPESI or the Hestia scoring system for low-risk patients. So these patients who have a SPESI score of 0 or low Hestia criteria, they can be discharged outpatient and can be treated there. In terms of anticoagulation for ESC, the DOACs are preferred. We do have low molecular weight heparin for pregnancy and cancer. Same goes for the other 2. Duration of therapy. So slight change here. There is some difference in the unprovoked. So there is 3 months for provoked, but for the unprovoked, we had this concept of indefinite lifetime anticoagulation. Now, the recent guidelines do recommend close follow-ups 3 months and 6 months to rejudge the situation and to reassess the need for lifelong anticoagulation. Same goes for the CHEST and the ASH. Cancer-associated PEs, DOACs are preferred over low molecular weight heparin unless they're high bleeding risk. And the high bleeding risk cancers are hematological cancers, lung cancer, prostate, and colon cancers. For thrombolysis, European Society, CHEST, they do agree that thrombolysis is reserved, so thrombolytics are reserved for high-risk pulmonary embolism only. In some select cases, we do have catheter-directed therapy for high-risk patients, but mostly for intermediate high risk. Catheter-directed therapy, as I just mentioned, is mostly for intermediate high risk with RV strain per European Society guidelines. And in CHEST, it goes the same, but also some of the high risk are included. There's an entity which is becoming more prominent now, and it's called the post-PE syndrome. People with pulmonary embolism always have complaints of long-term dyspnea, some chest pain, and this was not an entity until 5 years ago, where it was mentioned in the previous guidelines in 2019 by the European Society, but in 2024, this has become as a structured entity, and there's a structured follow-up. However, to note, CHEST in the 2021 did not mention post-PE syndrome, but did mention some post-PE complications. And there's a brief, PFO or paradoxical embolism. So there has to be a consideration if there's a cryptogenic stroke in PE, according to the European Society. The CHEST and ASH did not address that. So what am I trying to say? What I'm trying to say is that all these guidelines, they do have things that they do not agree upon, but at least there is 100% agreement on majority of things. Of note, this figure is from 2022, so this does not include the recent changes by, some of the changes by European Society, but pretty much anticoagulation is the mainstay, risk stratification, risk scoring, D-dimer, systemic fibrinolysis, identification of low-risk PE and IVC filters still stay the same. So risk stratification drives management. If there's one of the few points that you want to take away from this presentation, this is an important one. We will be focusing in the next few slides about risk stratification. It may get overwhelming. I'll try to keep it as simple, but this is my main reason of doing the presentation. I haven't seen much of a shift here in our hospital currently. We still have massive, submassive, and non-massive PE. That is the terminology is being used. But if we actually are aware of the recent guidelines, we may be able to bring that shift. So risk stratification drives the management. Okay, so pretty much our usual is the massive PE, the submassive PE, and the non-massive. I did do the color coordination to make it easy. Massive PE is acute PE with obstructive shock or systolic blood pressure less than 90. There's another definition. If the systolic blood pressure drops below 40 for a total of 15 minutes, without any reason, without any identified cause except PE, that's also considered a massive PE. We also have submassive PE, where there's acute PE without systemic hypertension, but they do have RV dysfunction or myocardial necrosis, which is shown by elevated troponins. And then we have the non-massive or the low-risk PEs. The massive PE coordinates with the high-risk stratification, so high-risk people. The submassive is with the intermediate high, and basically the non-massive constitutes of the intermediate low and the low risk. The only difference between intermediate low and low risk is that intermediate low may need a day of hospitalization for closer monitoring, and low risk can be discharged based on the SPECI or the HESTA criteria, as I mentioned earlier. So, we have heard multiple scoring systems, and honestly, during this presentation, it also clarified my own concepts. So you ask people about PE, there are so many scoring systems. All these scoring systems stands true, but they all have their own value. So some of the scoring systems here, which are the Wells criteria and the Geneva criteria, are basically the pretest probability. Then we have the PERC scoring system, which is ruling out. And then we have the risk stratification scoring system that is done by the PECI or the SPECI in the center or the BOA scoring system. All right, so this is something that I came up myself with all that I read. So if we have a suspected PE, someone who comes in the ED, and just to clarify, we as internal medicine, usually when we get patients, our patients are already diagnosed with pulmonary embolism. So the first few lines may stand true for my ED colleagues, but if you're working in the ED or if you are going for an admission and it has not been seen by the ED physician yet, suspected PE, you go for the pretest probability. When you do the pretest probability, you use two scores, the Wells or the Geneva scoring system. That defines our patients either into low intermediate risk or low intermediate pretest probability or high pretest probability. I should not have mentioned the word risk there. That's kind of like a misnomer. So someone with low intermediate pretest probability and someone with high pretest probability. We'll be talking about high shortly. So if someone has low or intermediate pretest probability, you then do the PERC score. If the PERC score, it has 8 components. If all those components are negative, you have ruled out PE. Even if 1 out of the 8 components is positive, then you would do the D-dimer testing. Now, what happens with the D-dimer testing? So if you do a D-dimer testing and it's negative, you have confirmed that there is no pulmonary embolism. If you do a D-dimer testing and it is positive, then you go with the CTA. So CT angiogram. And then with the CTA, you have a confirmed PE on the CTA. Now, someone who had a high pretest probability based on the Wells or Geneva score, they would directly go with the CT scan. Merging them both, if we do have a confirmed pulmonary embolism, now we're going to apply our risk stratification. So is our patient low risk? Is our patient intermediate low risk? Is our patient intermediate high risk? Or is our patient high risk? So let's talk about the right side of the slide, the low risk. Someone who has a S-PESI score of 0 or a lower PESI score, about 1 or 2, you can then apply the Hestia criteria on them and you can actually discharge the patient on oral anticoagulation and follow with them outpatient. But if someone based on our risk stratification is intermediate, high risk, or high risk, which is based on the PESI scoring system, so PESI of 3 or 4, or BOA above 2, then that's hospitalization and based on what is the treatment that we'll be talking about. All right. So I just put this in and I'm not going to go through all of this just because this is what we have been usually seeing. If you search up to date, you do see some places in the ICU in our clinic. We do have this table in a lot of places. This table stands true except that recent guidelines are just replacing the massive, submassive, and the non-massive with high, intermediate, low, and low risk. So why am I stressing so much upon risk stratification and how is that linked to the pathophysiology? So risk stratification in acute PE, what does it even mean? It means it's primarily based on the ability of the right ventricle to overcome the afterload which is caused by the thrombus. And you know, there was a French professor in 1884 who actually mentioned that venous thrombosis is always a severe disease and is often fatal because fragments of the thrombi may detach and occlude branches of the pulmonary artery. The occlusion of the main branches of the pulmonary artery causes a striking rise of the blood pressure in these vessels. This rise, which the right heart might fight in order to ensure circulation, may sometimes lead to cardiac arrest. And even 200 years later almost, or 150 years later almost, not 200, 150 years later almost, we still stand with the same principle that the biggest pathophysiology that we have to encounter and that we are fixing based on the risk stratification is the right ventricle dysfunction. So what is causing the right ventricle dysfunction? We have the thrombus in the left and the right pulmonary artery, which of course causes the right ventricle outflow tract obstruction. This causes increase in the right ventricular afterload, increase in the pulmonary artery pressure. We do have the right ventricle becoming dilated, and then it causes a leftward shift towards the left ventricle. That's what is the RV to LV ratio that we see on the echo and the CT scan. This Pushing towards the left ventricle, it of course causes decreased volume of the left ventricle, decreased preload in the left ventricle, and of course decreased output of the left ventricle, leading to hypotension, leading to shock, but this is the obstructive shock, and also ventilation perfusion mismatch. Very important to know here is that there is a difference in the right and the left ventricle. Right ventricle is a low pressure area. We can clearly see how there's a difference in the systolic and the diastolic between the right and the left ventricle. And because of this low pressure area, right ventricle has a lot of compliance, but it is not able to tolerate the afterload well. And as you can see in the graph below, as on the x-axis, as the afterload increases, the left ventricle, the red line, it kind of maintains itself and has a very slight drop. But as soon as even there's a slight increase in the afterload, the right ventricle has a drastic decrease in the stroke volume. So again, the same thing, acute P, increased afterload, RV dilation, decreased LV fillings, hypotension, obstructive shock, and death. I do have to make some important points here before we move on to specific treatment options, and that is, this is a shock, but this is not septic shock. So actually giving the 30 mg per kg fluid per sepsis protocol would worsen this patient. There's also focus on aggressive maintenance of MAP and coronary perfusion. We do have to make sure that when we are choosing vasopressors, they have to be some which are least offensive in elevating the pulmonary artery, pulmonary vascular resistance and right ventricular afterload. So usually it's norepinephrine or vasopressin that we use. And there is an oxygen ventilation mismatch. If you remember from our physiology, we have a negative intrathoracic pressure. Whenever we give a positive ventilation, in this case, if we intubate someone, it causes the intrathoracic pressure to be positive. That directly affects the right ventricle. What I'm trying to say is that in these cases, we usually stick with the non-invasive positive pressure ventilation, and we do not, or we avoid intubating the patients, those who actually need intubation, and we would rather go to ECMO. That's a totally separate topic, but just knowing in mind that intubation can actually sometimes worsen, based on the physiology, and the pathophysiology would worsen the right ventricle strain. So now that we have learned all the risk stratification, let's manage some PE cases together. We have 3 cases here, and I would want people to volunteer so we can just learn together. All right, I'll read the case and then whoever wants to answer. So 65-year-old female, history of breast cancer, status post-treatment, has GERD, comes with persistent cough, failed pneumonia treatment, vital signs, blood pressure slightly elevated, borderline tachycardic, really heart rate controlled, no tachypnea, maintaining oxygen saturation. D-dimer is elevated, troponins are negative, BNP is normal, creatinine is normal. CT does show pulmonary embolism. There's also pleural effusion and there's non-occlusive thrombus in the right iliac artery. The RV to LV ratio is normal. There's no McConnell sign. TAPC, as I had mentioned, less than 20 is something indicative of pulmonary embolism. TAPC is slightly low. The normal is 2.4 to 2.8, but it's still within normal limits. IBC is normal and is collapsible. So what score will you be using for risk stratification? What is the stage and what is the treatment?
Okay, we have the microphone, so you guys know the question. I'm got to phone a friend because I have no idea. What you
And
think?
I can be your friend. I can answer it.
Oh, hold on. Let's see. Somebody's got to know.
I think it would be, if you go based off of the old guidelines, it would just be a low risk or non-massive PE. But per your presentation of the new guidelines, this would be this last tier, which would be the low tier.
Good, excellent. All right,
And you can do outpatient management for
perfect.
the patient with Eliquis regimen.
That is excellent. Do you remember the score that we can use?
No, if Dr. Sun can help with that.
Dr. Sun, do you want to help?
Score. The score. We don't know the score. Does anyone know the score? Somebody's got to know. What is PERT score?
So so in risk stratification, this is low risk as, as mentioned. So Rashali, you were correct. This is low risk. And what did you treat it with, Rashali? Sorry, I didn't get it.
Outpatient?
Perfect. We can discharge this patient, either hospitalize this patient for a day or discharge this patient. Perfect. And the low risk, the score that we'd apply here based on our risk stratification would be SPECI, SPECI or PECI score. PECI is also applied because it's coming in the next questions. PECI and BOA is also applied for intermediate, high, and high risk, but this was a low risk. So good job, Rashali. Okay, so intermediate low risk, we didn't call this completely low risk. There was slight D-dimer elevation because this patient had a history of cancer, so this was kind of a provoked PE. So the SPECI is not 0. Anyways, there are like 15% of all the pulmonary embolism cases, but they are hemodynamically stable. The 30-day mortality could be between 8.9% to 15%. In patient management, this patient, just because it's not low risk completely, it's intermediate low, we may admit this patient for a day, do telemetry monitoring, supportive care, and then of course try to work out if there's any other causes that's causing this PE. For example, like DVT scanning, pretty much source control. All right, next question. Okay, but before that, so because we'll be starting this patient on DOACs, it's appropriate to talk about different trials, clinical trials that were done on DOACs in pulmonary embolism. If you see from 2012 to 2020, all these trials have the DOAC that is studied, and it is compared with enoxaparin or vitamin K agonist. The end point is that if you see the impact on practice from 2012 till 2020, if you see the impact on practice, rivaroxaban, apixaban, they have been approved or preferred for safety. If you see the RECOVER trial in 2009 and 2014, it did approve of dabigatran, but that required initial heparin. So the point here is that based on these trials, DOACs have been approved for monotherapy in low risk and intermediate low risk PE. All right, next question. 77 female, CAD, diabetes, presents with sudden onset chest pain, blood pressure is slightly elevated, is tachycardic at 108, no hypoxia, the high sensitivity troponin is slightly elevated, proBNP is elevated, EKG is showing what it always shows, the most common thing in pulmonary embolism, sinus tachycardia. CT chest shows bilateral distal PE, and POCUS shows enlarged RV with septal flattening. What score will you use for risk stratification? What is the stage and what is the treatment?
Okay.
We haven't discussed the treatment yet, so it's okay if you guys don't answer that.
So which risk, what score are we going to give this?
We're talking about the other side of the table now.
We're over here now. What you think?
Any guesses, guys? Give me a wrong answer. Yes. Yes, excellent, excellent. And if you go on the other side, what is the score that we would be using? BOA, yes, or we can use the PECI score. So BOA and the PECI score, excellent. So based on that, we didn't discuss individual components of BOA scores. The BOA score here was 4, intermediate high risk, as you guys mentioned. Intermediate high risk was treated with heparin RIP without IV TPA, because initially I mentioned, and I would be mentioning, TPA is reserved, so thrombolytics are reserved for high risk pulmonary embolism. If this patient remains hemodynamically stable after discharge, at 48 hours discharge, hemodynamically stable for 48 hours, we can discharge this patient. Now, this is the important category, the intermediate high-risk category, because this is where a lot of research has been done. So we use heparin RIP, we use anticoagulations here, but also the catheter-directed therapy, there are a lot of trials that have been happening in this particular group. And that is why my next question to you would be, could this patient be treated differently? And the answer is yes. So we had multiple trials in the past. This is just Thrombolytic therapy, if you say that this is intermediate high risk, there was a very, very famous PYTHO trial, or however you may say it, where it kind of like compared the use of thrombolytics versus heparin. So tenecteplase in addition to heparin versus heparin alone. What were the outcomes of this trial? The outcomes of these trials were, if you see, that the hemodynamic decompression was much less in the patients who had tenecteplase in addition to heparin. But, of course, those patients had high bleeding risk. So still, we have that gray area, very physician dependent, depends on how sick the patient is in that category, but most of these patients can go for catheter-directed thrombolysis. And these are the trials that we have. So we have the famous Seattle 2 trial, the Ultima trial that have supported the catheter-directed thrombolysis. A very, very famous trial that we should all be knowing that is in the process is the high PYTHO trial. And this is something that will be completed soon, as says on this next slide. So we have 3 current trials, the high PYTHO trial, the Peerless trial, and the PE Tract trial. If you see, all of these are sponsored by different groups. So one is Boston Scientific, one is Inari Medical, and the other is like NHLBI. All of these, so the high PYTHO trial is basically actually studying how important is catheter-directed therapy and how effective is it, does it have mortality benefits, and PE recurrence and all those things. That will be completed in August 2025, and hopefully we'll be seeing the results soon. And of course, we'll wait for the Peerless and the PE Tract trials. Because I mentioned all these, I'm just showing you pictures. So this is what they use for catheter-directed. Echosonic is something on the top right that is used by Boston Scientific. We have the FlowTriever, we have the Penumbra, and the thrombolytics Basher catheter. All right, so talking still about intermediate to high risk. Anticoagulation versus catheter-directed therapy. What do we know so far? We know that with anticoagulation, there have been multiple more and larger trials as compared to catheter-directed therapy. And the evidence for catheter-directed therapy is less, of course. Guidelines support, strong support to anticoagulation in all major guidelines in intermediate high risk. At all risk, it's the first line treatment. There is mortality benefit from anticoagulation in intermediate high risk. There has been no mortality benefit proven with catheter-directed therapy. And then, of course, the way it works, and then we have the notable trials, the Amplify, Einstein, Recover, Select-D, and Hokusai for the anticoagulation. And anyone who wants to go and read catheter-directed is Ultima, Seattle 2, Flare, and PYTHO 3 that's ongoing. All right, our last case. 70-year-old female, past medical history of diabetes, CAD, initial blood pressure was 104/76. It did drop to 90s, but was better after fluid resuscitation. This is troponin and not high sensitivity troponin. So troponin is 11, which means it is elevated. Pro-BNP is 4,000. We have sinus tachycardia with right bundle branch block. CT shows bilateral pulmonary embolism. POCUS shows massive RV dilation with biconal sign. What score will you use for risk stratification? What is the stage? And will you perform any imaging?
Okay, what do we think? What score?
I do have a hint. It's pretty similar to intermediate high risk, the score.
So it's PETI score, and this is very high risk, the highest risk.
Yes, so this is, so you said PESI score and then also BOA score. So BOA and PESI score, this is high risk. And the only reason why I asked you, will you perform any imaging? So this patient is hemodynamically unstable. So we did a bed sound, of course, like POCUS. So the BOA score was calculated at 7. This is the place where you use thrombolytics. Of course, you would, after using thrombolytics, repeat a formal echo. And then if this patient remains hemodynamically stable, can be discharged after 48 hours. All right, so talking about high risk. We do know that there's hemodynamic instability, there's cardiogenic shock, there is cardiac arrest. Systemic thrombolysis is the ultimate treatment of choice. There are certain reasons why you would not use systemic thrombolysis, and that is because of the absolute contraindications, which are mentioned in the box in the pink, and high bleeding risk. How do you assess bleeding risk in these patients? There are specific scoring systems. PE-SARD, which is PE, there's anemia, there's renal dysfunction, and then there's syncope, S for SARD, and there's like Re-Ati score that can be used to assess the bleeding risk in these patients. If there is high bleeding risk and thrombolysis is contraindicated, you can see the arrow at the bottom. They are the people for surgical embolectomy and catheter-directed therapy, and of course, they would be needing support with ECMO. Thrombolysis protocols, this is the European Society guidelines. We have the retaplase or the RTPA, we have streptokinase, we have urokinase. You all would have heard about tenecteplase. And why am I mentioning that? Because tenecteplase is something that we use, and tenecteplase is basically retaplase, but it's genetically, just bioengineered form of retaplase, and it actually lasts longer, is more specific for the site of thrombus, and hence results in low bleeding risk. These are some of the articles that I found that, tenecteplase and alteplase, basically in massive pulmonary embolism, have same effect on mortality and same amount of bleeding risk. And again, there was a meta-analysis in systemic review on tenecteplase that showed the, the benefits of tenecteplase in massive pulmonary embolism. Okay, coming to a very important concept, and that is the PERT team, or the Pulmonary Embolism Response Team. So what is this? This is basically multiple people in the hospital coming together, and as you can see, there are the pulmonologists, there are the critical care physicians, vascular surgery, interventional cardiology, cardiac surgery, ED, hematology, interventional radiology, cardiology, vascular medicine, pharmacy. All these people, they come together, and this is actually a concept that was, once this PERT consortium was held a decade ago, this is the concept that was brought up by them. There's an annual meeting with the PERT consortium every fall, and that is where all these teams actually come together and they discuss like what are the updates in the pulmonary embolism. And what is the advantage of having this multidisciplinary team? So basically they all talk together, and then they would actually, based on how the patient is presenting, they would come to a opinion, and they would be directing the treatment for the patient. Just want to mention that do pulmonary embolism response teams in acute pulmonary embolism improve outcomes? This is a very recent meta-analysis. So from April 2025, and it does show that the immediate mortality benefits, immediate hospitalization benefits, immediate bleeding benefits are much lower in patients who were seen by the PERT team. And there was a consensus of opinion between them. NGMC also has a PERT team, and this is an important slide. I think one of my friends, Dr. Farman from ED, he gave me the whole PE algorithm for them. I think the most important part for us would be most of the PERTs are activated by ED, but if we have a patient who's diagnosed with PE inpatient, what are we doing? So we'll be activating PERT team. I have done that once in my second year, and that was based on the BOA score of greater than 2, and then you call the access center, which is mentioned right there in the top one. It's 96400. If you are in another campus, and I was in Brazelton, Barrow, and Lumpkin, they have their, you would just call the critical care attending, and then they would decide if they have to call the access center. Any physician out of those groups, residents, after discussing with your attendants, can activate the PERT team. So just talking about overview, pulmonary embolism, high risk, intermediate, low risk, just as we mentioned, how do they present, all the treatments, the HESTA score, the simplified PESI score, all of that is mentioned here. We did talk slightly about the post-PE complications. So we need to know that for high-risk pulmonary embolism, the 30-day mortality is almost 15%. There's also 3% chance of patients developing CTEPH. Post-PE syndrome, which is persistent dyspnea, exercise intolerance without pulmonary hypertension, is an important entity now incorporated by the European Society of Cardiology. Recurrent VTEs, can cause high risk of unprovoked PE. So what are we doing in here? We are just having a follow-up for the patients, follow-up at 3 months and follow-up at 6 months, and then consider repeating imaging and echo, whatever you want. Of course, in any field that we see now, there is a role of artificial intelligence, and I found that a lot of the hospitals, not a lot, but a few of the hospitals, so the Royal United Hospital in the UK, they have an AI-enhanced CT interpretation wave where it detects PE and RV dysfunction, which cannot be detected by a regular physician. So they have that. There are also EKG-based AI model tools used by the Mayo Clinic. There is a triage workflow used by TriHealth, which alerts physicians and activates PERT. Then there's also risk score automation, so it's not easy to calculate all these PESI and BOVA scores, so I think that would be a good idea to have that incorporated. And then there is imaging prioritization used by other hospitals where this is flagged to the radiologist if there's a possibility of pulmonary embolism. All right, my last question of the day. What did the pulmonologist say to her husband? I'm sure you guys want to answer. Let me just tell you. You must be a pulmonary embolism because you take my breath away. All right. All right. Thank you, guys. I want to make a special thanks to Dr. Patel. Dr. Gross is sitting here. Thank you so much. Dr. Tashomi, Jackie, you guys gave me excellent feedback on my presentation and really helped me make it better. I really thank you guys for your mentorship. Thanks.
Thank you, Dr. Rana. If you're viewing online and have a question, please enter it into the Q&A section and we'll ask that for you. Are there any questions or comments in the room?
Thank you, Dr. Rana, for an excellent talk. My question is, I know we use systemic therapy for the high-risk ones. Did you run across any articles or any guidance about half dosing your TPAs or your systemic therapies in those with intermediate high risk?
So I did actually, when I was searching different cases, and actually the cases that I took were from chest. In one of the cases, the high-risk case in that particular article, they had used and they were actually studying the role of doing the half dose of TPA, and what they were proposing was that it was same as doing full dose of TPA. It has not been approved by any society guidelines so far, but yeah, that's a great question. I just came across that, and that's why I just put on those two cases. But just to follow the guidelines, I answered it as full dosing. So thank you.
Thank you.
Yeah, Schaza, well done overall. I think this is a good example, ground rounds, to share with others. You're very knowledgeable on the subject. You shared all the evidence. It was very colorful and interactive, and impressive that you made your own figures as well.
Thank you.
I'm curious, how long did this take you to put together? You can tell you're passionate about this topic, and yeah.
It took me a long while. I think like, I just have this thing for presentations. If I'm presenting at a big place, I'm not sure if this is efficiency, but I just have a passion for presentations. So I do, once I'm done making it, I did put at least like 8 to 9 hours decorating the presentation. I know that's not efficient. I don't recommend that, but that's just my passion.
Yeah, it turned out fantastic. Good job.
Thank you.
This was a very good presentation.
Thank you.
So just like how we have a, I guess, time protocol for ischemic strokes and everything in terms of TPA, is there also a timeline, like protocol for who can get the TPA based on how fast they arrive, or is it just primarily based on if they're high risk PE?
That's an excellent question. I did not come across any timeline. Of course, it may be something that is like, maybe it exists in the literature, but I did not come. So there's no like balloon to door time, as we say there, because what usually happens is if you're making the per team call, maybe you do give like, you have a quick discussion and you do give thrombolytics there and then. But I would go back and look into it, and if anyone else comes across, I'll be happy to, get that knowledge from you guys. A good question, Roshali. Thank you.
Thank you.
Excellent presentation, Schaza. I just had a couple of questions. What about the fluids? So one of the intermediate risk cases, she had, no, it was, I believe, the high risk case. She was hypertensive and she received fluids. Again, I'm not sure if there's like a sweet spot for the fluids for someone who's hypertensive and also has a PE. So did you encounter anything about fluids, especially if the patient has like sepsis along the line? Does that take precedence, or how do you manage that? And if there's no sepsis, do you just like let the low blood pressure be until you give thrombolysis? Same goes for intermediate risk patient. Is there any role for diuresing patients if they had stable blood pressure to kind of offload the right ventricle, or there's nothing specific in that regards?
Got it. That's excellent questions. Okay, so fluid. What I meant by fluids was, so by definition, massive PE is either systolic blood pressure less than 90, obstructive shock, or another definition is greater than 40 decrease in systolic blood pressure, which is not responding to fluid. So our patient was meeting the first two criteria. I wouldn't say not giving fluids, so there's always a fluid challenge. Hypotension, I think our first goal should be giving fluid challenge. When we say fluid challenge, it could be small boluses, seeing how well the patient is responding. There could be concomitant sepsis, and in that case, of course, it complicates the situation. There's definitely then the role of 30 mg per kg. But if you give your patient a 500 ml fluid challenge and the patient is worsening, reconsider your decision, just because in sepsis, we do highly recommend still giving 30 mg per kg, which is like good amount of fluid. So I want to say no fluids. I would say be very conservative when you're giving a bolus challenge. And my point here was, do not consider this as septic. If it's only an obstructive shock, giving that 30 mg per kg may worsen. But fluid challenge is almost like, it's always there when you have hypotension. The second question for intermediate high risk, I have not come across any rules of diuresis. I mean, when we are in a practical situation, of course, we do any and everything to reverse that situation. So we have multiple modalities. But based on the pathophysiology, it's the clot burden that's actually causing the RV afterload. And initially, there's no fluid there. So based on the physiology, and I may be wrong, diuretics do not stand a chance in the initial. Of course, when you have fluid pulmonary edema, like all that stages that I mentioned, and in the end you have pulmonary hemorrhage, you may have pulmonary edema from then, that may help diuresis, but not in the initial phase. I did not come across that.
Thank you so much. Great presentation again.
Thank you.
Sorry, I just thought of another question.
Sure.
When you were researching, did you come across like nitric oxide for high-risk PE, or is that something that's primarily just used for hypertension?
I did not come across that. That could be something for someone who has chronic PE, I believe, not acute PE. It could be one of those things. I did not come across something in acute PE.
Thank you, Dr. Rana. Great job.
Everyone, thanks a lot.